So our next presenter is Dr. Lari Wenzel. She's a professor in the Department of Medicine in the program in Public Health in the College of Health Sciences at the University of California, Irvine. She's going to talk about her experience in patient-reported outcomes in clinical trials, healthcare disparities, and decision-making.
Thank you. So have any of you ever seen the movie Groundhog's Day? Heard of that? Okay, so I have to tell you a quick funny story. Yesterday, just before I caught a plane
You
to
want
come
this to
here.
be off the record?
Absolutely. we were having a cancer center site visit rehearsal, and the podium was there, and there was something called a confidence monitor, which was roughly beyond those glass doors. And I had notes at the podium, but no computer. And so what I realized when they dimmed the lights was that I couldn't see the confidence monitor. So during the rehearsal, I had no access to my slides. So I stepped around the podium, went into the audience, and stood in front of the confidence monitor. And now today, so this is the Groundhog's Day experience, is it's teaching me to be less podium reliant. I am grateful for the 24-hour experience. So I'm also grateful to be invited to be here today to talk about quality of life, patient-reported outcomes, and survivorship in ovarian cancer. And by way of introduction, I'll talk a little bit about the patient-reported outcome measurement contributions to current trials and future trials, because I imagine many of you are very familiar with this body of research. And then a new area which we're calling symptom indexing and symptom concerns, and how that's going to be evaluated and assessed in future ovarian cancer trials. Then targeted interventions, touch very briefly on that, and then finally ovarian cancer decision making. So it's a panoply to cover in 15 minutes. So Tony mentioned this before, actually, this graphic on what is the difference between quality of life, health-related quality of life, and PROS. So quality of life is the overall evaluation, whereas health-related quality of life is what we're all concerned with when we take care of cancer patients. PROS is a relatively new term, actually, stemming from work of the FDA, patient-reported outcomes, anything reported by the patient. When I talk about PROS, and I'll show you an example of that, I tend to think about them in terms of a particular index or a particular measurement, such as neuropathy, versus health-related quality of life, where you might have a more generic scale and generic scores. So it's important to set the stage in terms of clinical benefit in oncology and what our health-related quality of life does. As you know, there's an ongoing debate about what appropriate trial endpoints are. We often consider overall survival as the gold standard. Yet, and particularly in advanced ovarian cancer and recurrent ovarian cancer, surrogates like progression-free survival are often used and often valued. But these traditional endpoints don't fully address treatment responses, particularly as it's reported or experienced by the patient. And this is where you really want to have some very solid, psychometrically sound measures that are going to indicate symptom relief, and then how you're associating symptom relief with functional improvement. So this is where our outcomes can actually and do complement traditional efficacy measures. So this is one such example. I apologize that you can't see this too well. This is a relatively recent publication of the Aurelia trial, and this is what I would call a patient-reported outcome, where we actually powered the study based on what we thought we would see in terms of improvement for women responding to chemotherapy plus bevacizumab. And that improvement would be according to abdominal or GI symptoms. And in fact, the women who participated in the chemo plus bev trial did have significant improvement in their abdominal symptoms. And that, by the way, also held true across our health-related quality of life measures as well. So when we're assessing our patient-reported outcomes, there are several points that have, the first point has been published repeatedly, and I'll show you an example of that also, the second one less so, but that our patient-reported outcomes are actually, and health-related quality of life in particular, is correlated with survival, and is often correlated with tumor response. What we've more recently seen is that these elegant, sophisticated, already well-tested and well-utilized measures can dictate symptom patterns longitudinally. And that can signal advancing disease or remitting disease. Additionally, our health-related quality of life assessment therefore becomes a very important piece of information together with the rest of the information in a clinical trial as it's experienced by the patient. And it's very important to note that the patient's voice here is an important one. So this provides you an example, and this actually, thank you to the authors of this study who just presented this last week at SGO in the late-breaking session. This is on the relationship between baseline quality of life and changes over time or trends over time in quality of life and survival. And so what they found in GOG 218, again, and we've conducted this now several times, is that the baseline score, so that's the FACT-O trial outcome index, which indicates physical well-being, functional well-being, and additional concerns, which is both symptom-related as well as treatment-related concerns, actually can predict both progression-free survival as well as overall survival. What has been less documented and what's novel about this study is that they were able to track in ancillary studies that you can see trends in either improving health-related quality of life or deteriorating performance, and that too is associated with progression-free and overall survival. So there are some important implications here as you're looking at how we're measuring response to treatment. So next up is symptom indexing and symptom concerns. We have, over time, established various ways that people value and measure symptoms, and clearly one of the most important ways is by asking the patient how she's doing. So here I'm giving credit to Heidi Donovan in our midst and at your table, who is the PI of a study, GOG 259, with recurrent ovarian cancer patients. And she asked several important questions. One is, what are the most prevalent symptoms of women with recurrent ovarian cancer? And what she and her colleagues found was that you can see that over 70% of the women with advanced ovarian cancer experienced fatigue, anxiety, memory problems, peripheral neuropathy, and sleep disturbance. So again, this is a common symptom cluster that has been described earlier in several presentations. It's also noteworthy that fatigue is the #1 complaint of all cancer survivors and cancer patients, and possibly people in this room. But then when you also ask what are the top 3 where you actually might need some help, how would you rank this? Again, people say fatigue, peripheral neuropathy, constipation, pain, and sleep disturbance. So very important questions to ask, and the kind of work that Heidi has been doing through this GOG trial is really groundbreaking. So as a result of that and several other studies examining symptom clusters, we had a symposium at NCI about 2 years ago now. And we asked people with expertise in this area what you would consider the most salient patient-reported outcomes across all ovarian cancer clinical trials. And so these enlarged bullets are what the expert panel considered the most important for ovarian cancer clinical trials. Now, I can tell you that there was some concern or a large amount of conversation when it came to the more emotional, less symptom-oriented aspects, such as fear of recurrence, fear of disease progression. Nevertheless, it was the survivors in the room who told us this is equally important. This is a concern, it continues to be a concern of survivors. And the text in the bottom, the smaller, is what people also recommended as potential patient-reported outcomes for clinical trials, but that also is consistent with cancer patients across different tumor types. So now moving on to targeted interventions. Again, I want to give credit to symptom intervention management and then talk about how that might influence treatment preferences, which is also a new and emerging area, particularly within recurrent disease. So this is the design for GOG 259, and Heidi and colleagues actually recruited more than 400 people. I can attest to the fact that their accrual was actually brisk. So they met their accrual and extended it, and that's very rare in a behavioral clinical trial. So I think it's a testament to the need and the desire of this population. So this is a web-based approach. We do not yet have results. We will have results very shortly, but I at least wanted to give you a glimmer of what's coming in the near future. But again, a very novel way to intervene on symptoms, symptom management, and a web-based approach for women with recurrent disease. So how do patient reported outcomes relate to treatment preference, or do they? Well, as mentioned, overall survival might be considered the gold standard, but yet we address progression-free survival, and that's a notion that's addressed with patients. Now, how do they understand progression-free survival? Well, through the patient treatment experience, they might report aspects of disease symptoms, they might report side effect burden, and certainly tolerability. Now, tolerability is a question that's now emerging in a current environment where people are, for example, examining benefits of olaparib and cediranib, the protocol that Tony mentioned earlier, where how is the patient tolerating the treatment, how does that impact the other outcomes or quality of life, and does that in any way influence treatment preference? And this is the point where I would argue for asking the committee to consider that as we're improving cancer treatment for this population, that many of these women are becoming women with chronic disease. And the chronic disease happens to be ovarian cancer, but while it's life-threatening, when you're hearing the stories of people who have lived with this illness for 5 years, 10 years, on repeated different therapies, the notion of treatment preference and how she evaluates that within the context of chronic disease is important. Which leads me to whose preference matters. Traditionally, health economists might say that usually they take a societal perspective. The problem with the societal perspective might be it excludes hope, and it excludes your capacity to adjust to a situation. So in fact, when you actually ask someone who is not a cancer patient what they're willing to tolerate, they may often overestimate the disutility or overestimate the cost associated with that treatment. But yet the patient's actual preference matters very much, both for individual decision making and notably, her preferences may change with experience. So the questions we ask a newly diagnosed patient, her answers may be quite different 2 years later after having gone through treatment. So how can we really help patients know what lies ahead? And that therein is the issue of treatment preference and patient-reported outcomes. So Laura Havrilesky and others at Duke University have examined this by looking at relative influence of the factors determining a woman's preference for treatment. And they've arrived at two conclusions. One is that progression-free survival is the predominant driver of patient preference for chemo. And the other is that women are willing to trade significant time for reductions in treatment-related toxicity. So that is an important message from the survivor community. So that leads to the last portion of this talk, which is if patient preferences and expectations are to be considered in the panoply of information that we offer them, how do we help them to make decisions? So we are right now working on a PCORI-funded trial on decision making, and this has to do with the difference between IP and IV therapy. For those of you who know, intraperitoneal chemotherapy is more aggressive, but it also confers longer survival. Nevertheless, an NCI clinical alert came out because while they advocated for use of IP treatment, the uptake in the community and other institutions has been slower than NCI would have wanted. So the question in this decision-making tool is, can we describe these therapies in a way that the woman can help to determine what the important trade-offs are, to assist in her speaking with her clinicians as she's choosing a treatment? So very briefly then, the structure of this is an iPad-based intervention, educational intervention that has 3 modules. One is educational, explaining the implications of the toxicities of both IV treatment and IP treatment. Then there's a preference elicitation exercise. So how would she rank the toxicities and what is her value? It's called a time trade-off of healthy life relative to the worst toxicity. And then the last module is the result of this, which then she and her physician discuss together. And several of you in the room are involved in this study, and I am grateful to you. So this is just an example of one of the educational modules. So this was very much survivor-driven. Every single aspect of this study involved ovarian cancer survivors. I bring up the educational module of peripheral neuropathy because this is the one area where many of our survivors said, I had no idea this was going to happen to me, and some women who actually read the script and said, oh, that's what I have. So at least we provided one piece of information that was valuable to a majority. They then go on to rank side effects, and they do this on a little bar, and they are ranking side effects associated with peripheral neuropathy, pain, nausea and vomiting, and they move this bar around until they've determined what their particular value or concern is, whether their concern is extremely high related to this toxicity or quite low. So I've whipped through an enormous amount of information. What I wanted to give you really was things that are here and now and might be coming into the future. So one is this notion of symptom indexing, where you actually can measure disease-related symptoms and treatment side effect concerns. They can be coupled, they can be measured distinctly. That will be able to help you determine how well people are responding to treatment or not. And then to keep the survivor's voice in the picture is that just focusing on symptoms is inadequate. And one of our vocal survivors said setting the bar too low on the continuum of minimal expectations versus aspirations is unacceptable. And then finally, noteworthy that I think we're going to be seeing more biobehavioral interventions, more symptom management interventions for our advanced ovarian cancer patients because they are living longer, but they're not symptom-free. So we ought to be looking towards the future in terms of symptom management and quality of life intervention and decision-making in the recurrent setting. Thank you. Sure.
So a number of the side effects that you're talking about are common issues among individuals that have other diseases. So has there been any effort to sort of link, you mentioned peripheral neuropathy a lot, you mentioned or sleep disturbances, to link sleep medicine doctors or neurologists into the ovarian cancer care continuum? And has there been any sort of effort to try to assess whether there could be overlap in the treatment of those disorders with other diseases, and how it's treated in other diseases?
Sure. Well, that's a great clinical care question, and I would like to defer that to some of our great clinicians. I think there's huge variability between medical centers, between community hospitals, in how they integrate, a rehabilitation approach, for example, or a holistic approach to care. So I imagine that varies.
So do you think there's research efforts that should be targeted towards something like that, and if so, what?
So in terms of integrating care into the ovarian cancer panoply of their experience of treatments, I would see that as ideal.
Let me ask Tony a question. So how do you take this information and factor it into your clinical development program for a drug to be used to treat opioids?
Oh, we actually take this, we do integrate this, so a couple of things we're doing. For example, when I just pick up the PARSA program, the quality life only collected to progression and actually doesn't collect that post-progression. And then we actually changed that. And the other thing we're very interested in these PRO is also this gives us argument to the payer to say, well, why is this valuable? You know, and these are, we wish we have this information during ODAC when people ask, like, gee, you know, why is PARSA is important? Unfortunately, we actually didn't do a good job of collecting quality of life. And the thing is, when you talk to PARSA patients, they love this drug. This is a drug they can take every day. But you know, this is where we wish we knew a lot about these, and we're doing this with NCI. So have these PROs in place, so we can collect these very important information.
So we are working together
Yeah.
on two of these upcoming trials.
Yeah.
Lots more questions.